A 43-year-old patient with menorrhagia underwent transvaginal sonography and that revealed a G0 submucous myoma of 2 cm by 1 cm. She was counseled for office hysteroscopy and then we performed a mapping hysteroscopy with the tissue retrieval system in office. As you see, we enter the endometrial cavity atraumatically by vaginoscopic technique. You can see the blade moving, oscillating, and we sucking out all the debris from within the cavity to see the myoma on the posterior wall. It is a sessile myoma arising from the posterior wall. The Lasmar score of about 3. We place the soft tissue incisor blade onto the apex of the myoma, and with continuous suction and cutting we start then retrieving the myoma into the canister. We go around the periphery of the myoma to highlight the myoma completely and then place the window exactly onto the fibroid, and then with the oscillatory movement, continuous aspiration and cutting, you can see the reduction in the size of the myoma. While doing this, there is no air bubble seen, no floating chips seen. You can see now that we slightly tilt the blade so as to remove the edges of the myoma. The rest of the endometrium is not touched by us. No bleeding is seen during the procedure, and gradually and steadily we reach the base of the myoma. Now, as we reach the base, we try to locate the pseudocapsule of the myoma, and for doing this, we go around the periphery of the myoma and then insinuate the blade within the edge and the myoma so as to enter the pseudocapsule. You can see now we elevate the myomas by tilting the blade slightly, and we'll notice that is not a G0 myoma, but there is a small intramural component to it. This also has to be removed, and this is feasible in the office setting. The patient has not received any form of NSAIDs, no pre-medication, no misoprostol. Patient is conscious and is involved in the procedure. Now you can see that we are going beneath the myoma, and you can see us elevating the myoma from the pseudocapsule up. Throughout the procedure, we do not leave the contact of the blade with the myoma. The pseudocapsule once visualized, we tend to remain above the pseudocapsule and elevate the myoma up so as to remove the myoma from its attachment. The pseudocapsule protects us from inadvertent bleeding and also doesn't allow fluid to be absorbed during the procedure. Within a few minutes now, we will be completely eating into the myoma, and the mantra is to stay above the pseudocapsule. Small last few part of the myoma is remaining, and the trick here is to put the blade upward facing the anterior wall so that you can elevate the myoma from the bed. Throughout the procedure now, the pseudocapsule is under view. There is no bleeding. You can see the black vertical line which indicates the window of the incisor blade. The total time taken for this procedure was about 10 minutes. The visual analog score was just 4. And now you are seeing that we are just trimming the edges to remove the small last fibers of the myoma. One can now appreciate how big the base is and that some part was within the intramural region, and therefore this is not a G0 myoma but a G1 myoma. So, using pre-hysteroscopic proper diagnosis, counseling the patient, and then using the right instrument for the right pathology, we are able to remove a pathology in office setting without causing much harm to the patient and being still cost effective. You can now appreciate the fovea clearly, and only a few fibers of the myoma have to be trimmed now to get the complete picture of the pseudocapsule. This fovea closes as soon as the uterus contracts, and post-operatively there is no bleeding that is seen. Thank you so much.